Dr. Rachel Manber is a seasoned behavioral sleep medicine clinician and researcher. Clinically, she specializes in non-drug treatments of sleep problems in adults, youth, children, and infants. Dr. Manber has over 30 years of experience treating patients and conducting research to improve non-pharmacological treatments of insomnia. She has led research projects and real-life initiatives to increase patient access to cognitive behavioral therapy for insomnia. Her research has been funded by multiple NIH institutes, including NIMH, NINR, NIA, and NLHBI. Most relevant to this presentation is her research on CBT for perinatal insomnia. It is such a pleasure. Please join me in a warm welcome, and I will pass the mic to you. Thank you very much.
Before I do that, I realized my door is open. Let me shut the door before I start.
Yeah, sure thing.
Sorry about that. So let me share my screen. I hope this is not timed in any way, but so going back to my previous slide, so what I'm going to talk about today is indeed about my research on CBT for insomnia in the perinatal period. And I want to start with a few introductory slides to give you the kind of the context. So when trying to estimate the prevalence of the problem of insomnia during pregnancy, people have used different tools. So my first slide is a meta-analysis of people using a measure of sleep quality, which is not quite insomnia. I don't know, there must be a timer on my slides for some reason. So hopefully it won't skip me out of here. So this meta-analysis had 24 studies, and the measure is the PSQI, which is the Pittsburgh Sleep Quality Index. And a score above 5 or above is considered significant to poor sleep quality. And so when you use an estimate based on sleep quality, you see that about half the women have poor sleep quality during pregnancy. And what we know is that from the second to the third trimester, the score on the sleep quality gets worse. A higher number means poor sleep quality. So that's kind of one way to look at it. However, poor sleep quality is not the same as insomnia. And when we look at insomnia and we want to think of insomnia disorder, then we need to look at difficulty initiating and maintaining sleep that has certain frequency and duration of the symptoms of at least 3 months nowadays, with frequency at least 3 times a week, that has associated with it significant clinical symptoms during the daytime. And when you use that, you see a marked difference in the estimates of the prevalence, which range between 12% and 17%, depending on different cutoffs. This does not all come from the same study. But when you do diagnostic interview, we find that the prevalence is about 19% in a paper that we recently published by Bay, which I have not included the reference here, my apologies. And Jody Mindell has found in an earlier study that when pregnant women talk about what disturbs their sleep, they frequently associated most frequently to the frequency of urination and positional discomfort. So the challenge in diagnosing insomnia during pregnancy is how do you distinguish experienced symptoms and disruption to your sleep from a disorder of insomnia, which explains to you why you have such a discrepancy between poor sleep quality and severity of an insomnia as a diagnostic of disorder. Poor sleep quality was studied in relation to pregnancy outcome, and the literature on that is quite complex and not always consistent, but some of the more consistent findings is association with increased odds of preterm birth and increased likelihood of undergoing cesarean section. And the most robust literature is on increase the risk for perinatal depression. And in the audience is Jan Felder, who's exactly targeting how to reverse the progression to depression among women during the perinatal period, addressing their insomnia symptoms. So what I want to focus on today is my study, which was a randomized controlled trial of CBT for perinatal insomnia. It was funded by the National Institute of Nursing, and the main outcome was published in 2019, in which we published the pregnancy outcome. The study is rather complex, so let me describe to you what is the experience from the perspective of the participant. So a patient gets into the study anywhere between 18 and 32 weeks of gestation, being screened, providing baseline information, then gets into, during pregnancy, into 5 sessions of CBTI or control, which I'll get to in a minute. And then after that, assessed at time point 1. And then depending how early in pregnancy she entered the study, she will then wait for a while being potentially assessed, because we try to get monthly assessment until birth. And then after the birth of the child, there's one additional session in which, and after a week or 2 weeks after that, we do a second assessment for the postpartum outcome assessment. And then we have a no treatment follow-up at time point 18 weeks postpartum and 30 weeks postpartum. So that's kind of the extent of from the perspective of participant, that's the graph we use to explain what to expect as being a participant in the study. So the treatments, the active treatment is CBTI. It was minimally adapted for pregnancy, specifically to address sleep-related beliefs and cognitions that are unique to pregnancy. So, for example, it's not possible for me to sleep better because pregnancy will continue to interfere with my sleep, or worries about the impact of not sleeping enough on the developing fetus, and reaction to the time in bed restriction, which is part of CBT for insomnia, in terms of worrying that if they restrict their sleep, then they might harm the infant. So we need to kind of work with that. But in addition, although traditionally time in bed restriction is implemented by saying, let's look at your average total sleep time in the past week, and in the next week or 2, we want you to not sleep more than that average. So you should not be in bed more than that amount of time. In pregnancy, we did not use that strategy, but instead we tacked on 30 minutes to the mean total sleep duration as the recommended time in bed. We also helped women adapt the time in bed during the postpartum to account to the fact that some of the time that they're awake at night is necessary to take care of the infant. So we kind of factored it out of the equation. So the adaptation was look at your average total sleep time and the average time you spend taking care of the infant, and add, I'm sorry about, I don't know why it keeps doing this advance. And add to it the average.
Rachel, you can exit the PowerPoint and you can get rid of the timing.
Okay, guide me through that.
Go to slideshow on the top menu. Slideshow.
Uh-huh.
And then there should be a thing called time. Use timing. There's usually a little box in the middle. Yeah, just get rid of that. That's it.
Okay, thank you so much. That was very annoying. Thank you, Ali. Good to have you. Okay. So that's basically the minimal adaptation that we have made for CBTI during the postpartum period, during the pregnancy and the postpartum. We also included a component about infant sleep. So in session 4, we started by providing some information about how the infant sleep develops in the first 6 months. And at session 5, which is the last pregnancy session, we talk about how to best set the stage for optimal infant sleep. So we shied away from talking about sleep training and instead talked about notions such as putting the baby down, sleepy but drowsy but awake, connected it to what the woman already knows about the association between sleep and bed, or the sleep cues around sleep that promote better sleep for her, and applying it to her infant. We talk about recognizing signs that the infant is tired and needs sleep, and being attentive to cues, etc. We also brought the partner in at the last session of pregnancy whenever it was possible, where both the woman and the partner have completed a measure that provides different vignettes related to infant sleep, and then ask them to rate what is the right way to behave when the index there is, should you intervene or should you let your child figure out their problem on their own, kind of thing, for different ages and different scenario. And we basically looked at this in relation to how well do the two partners agree on how to address the issues that might be arising, and help them facilitate a discussion between them so that they'll be on the same page. And we did it again at session 6 after the baby already arrived. I'm not going to talk about this portion at all today. Ali, who just helped me with the slides, is just now beginning to look at the data that pertains to that particular vignette and how relevant it is and how it changed. The control treatment, I call it on some slides I call it control, and on some slides I call it ABTI. I called it, that's a name that I've invented for it. In the literature, it's called DTI, but we call it arousal-based therapy for insomnia, and we wanted to increase the believability that it's actually an active intervention, and it was very highly believable both by the therapist and by the patient participants. And it's based on a control that Jack Edinger has used in his 1989 JAMA paper that does a pseudo desensitization, where women are instructed to led through creating a hierarchy of situations and scenarios when they cannot sleep, and then do some exercises pairing them through imaginary pairing with neutral actions, such as cutting vegetables, or driving to work, or something that's not high arousal or low arousal. And in both cases, people were given homework to practice, in this case, that pairing exercises, or to follow the recommendation of CBTI. The control treatment also wanted to control for attention to infant sleep, but we simply provided them with very basic information about infant sleep development and gave them the handout for the American Pediatric Association guidelines for infant sleep. So the control treatment, I would say, was a very active intervention. It was not totally benign. And even though women were instructed not to do the pairing exercises when they're trying to fall asleep, I did debriefing with many of them, and I asked them what has helped them. And quite a few have said that they did this exercise to help them relax, that it actually was like a relaxation for them, which could be very powerful. So overall, as I say, there were 5 sessions during pregnancy and 1 session in the postpartum. Initially, we started with nurses as therapists, and we trained BSN nurses to be therapists, but we couldn't keep them. They kept moving out of the area because they couldn't find job in the area at the time that we conducted the study. So we switched to training, because it was a lot of effort on our part to train them. So we switched to training graduate students. And so we have a combination of both. They were all naive to CBTI. They were trained to competency. And we used the standardized patient methodology to train them. So we had actors and we created scenarios for different situations, and we recorded them and we rated them until we felt they were competent to deliver the intervention. So the inclusion criteria were the pregnancy week 18 to 32 weeks. They need to have met diagnostic criteria for insomnia based on the SCID interview, except that we modified the 3 months duration to only 1 month duration. And they had to be speaking either English or Spanish. We provided the intervention and all study assessment and procedures in both languages. We excluded women who currently had major depressive episodes, had PTSD, substance disorder, thought disorder, were taking medications for sleep or medications that are stimulants, having ever received CBTI. And we also excluded potential other sleep disorder, including sleep apnea, periodic limb movement disorder, restless leg. Restless leg, we did allow women with onset during pregnancy, but we did not allow women whose frequency was more than 3 weeks who started before entering pregnancy, because the emergence of some RLS symptoms during pregnancy, we felt it is important to still show that CBTI can deal with that issue. We excluded for severe circadian rhythm sleep disorders, which means extreme schedules like going to bed after 3 or waking up after 11, or going to bed before 8 and waking up before 4 o'clock in the morning. We excluded for shift work or night work, and we excluded for nightmare and other parasomnias occurring more than once a week. So overall, we assessed for consented 299 women. I'm using the word women here because that's how we construe the study. I think nowadays the correct terminology is pregnant people, but these were all women, so please allow me to use that term. We excluded then 105, 45 because they did not complete the screen, and then 48 were not eligible. As you can see, most of them because they had not met criteria for insomnia or had comorbid psychiatric condition or a comorbid sleep disorder. We had 12 participants who were eligible, but did not proceed to randomization for whatever reasons. And so we remained with 194 participants. However, as I'm going to show you, we had to exclude 10 women from our analysis because in order to quickly assign and find a matching time between the therapist and a participant once she completed baseline, particularly since many of the women started late in pregnancy and we didn't want them to deliver before they finished treatment. Once they qualified for the study, there was a separate treatment coordinator that was not blinded who actually created randomized people, but did not tell anybody in the study and did not tell the patient either anything, but matched a patient to a therapist and scheduled the first session. So when the patient is randomized, quickly thereafter, the participant could start treatment. But what happened as a result of this delay is some women fell between the crack and never completed the baseline. And so technically they were randomized, but in reality, they never completed the baseline, so we couldn't use them. And so as a result, we had 96 were randomized to CBTI, but only 89 were included, and 98 were randomized to ABTI, and only 90 were included. So that's kind of a little bit of a quirk in this data set. But not everybody began treatment. However, we included even those who did not begin treatment in the analysis. And you can see that the number is similar between the two. 71 in CBTI completed all 5 pregnancy sessions. The reason they did not is delivering too early 2 stated time commitment and 2 lost contact. But in ABTI, you have an additional, a little bit more, I would say, stop treatment because they did not like treatment. And it includes 2 specifically say that, but I think the fact that you have 7 time commitment and 2 time commitment suggests to me that some of the time commitment could have been a disguise not liking the treatment. It's a speculation. So we have recruited participants from 3 sites and we randomized within 3 buckets. So separate randomizations were happening in each of the sites. So one of them was Stanford obstetric clinics across the Stanford system. The second one was Santa Clara Valley Medical Center. And to kind of capture not a university-based healthcare system, but a community-based healthcare system. And as time went by and we were slow to get our target, we created a new bucket in which we advertise on Facebook, and we call it a community advertising. So all the women in that bucket were all similarly randomized within that bucket. To increase enrollment of Latina, we had bilingual, bicultural staff, and we provided options to complete the assessment and treatment in Spanish. And I'll give you some data of how many women opted to do that. So what you can see is some sample characteristic by site to see site differences. And I want to highlight that really the difference was between Santa Clara Valley and the other 2 sites in that women were slightly younger. The representation of Hispanic Latino was much, much higher. Overall, we had 38%, but 78% came from that site. The proportion of women who were very low income, which we defined as less than $55,000 based on the way we cut off criteria and the demographics in this area. And of course, related is that 65%, almost two thirds of women in Santa Clara chose to receive the therapy in Spanish. And so this was in that way a very unique site. The primary outcomes were the Insomnia Severity Index, which is a 7-item questionnaire that measures both symptoms of night and the impact during the day. And the total amount of time awake, which is the sum of how long it took a woman to fall asleep plus how long was she awake in the middle of the night. We also report here today, I would report some proportion of remission of insomnia, time to remission, some other diary measures, and depression. So as you can see, 50% of the, roughly 50% of the sample were white. There is no difference in the distribution between the 2 sites in racial distribution, Hispanic ethnicity, mean gestation age, which was approximately 25 weeks, proportion of women for whom it was the first birth, which was around 55%, and therapy in Spanish did not differ between the sites, and baseline severity of both depression and insomnia were not statistically different between the sites. So between the, not the sites, but the treatment arms. So let's look at some outcomes. So remember, the insomnia outcome that I'm talking about right now is just during pregnancy. It's not for the whole treatment, which also included postpartum. So very clearly, there was a separation in insomnia severity between the control, which improved, and the active intervention. And as you know, as pregnancy progresses, sleep worsens, if you remember one of my first slides. And so the fact that we can still see an improvement, despite the fact that we are going against the current of natural increase in worsening of sleep, is quite remarkable, and in both conditions. The effect size for between group difference was for ISI at post-treatment was 0.6, and for the change from baseline was 0.5. Both of them fall in the moderate range. But remarkably, there was no difference in outcome for Hispanic Latina, for language of therapy, for the time in which, during pregnancy, in which women entered the study, for maternal age, or for recruitment site. So it is pretty robust finding across the board, which I think can tell us that at least in terms of insomnia severity, there was a significant difference between CBTI and control. However, we looked at potential predictors of comparing Latina to non-Latina Caucasian. So that's not the whole sample. Many were excluded because they were in other races. And for whether or not they will actually start treatment, because we had so many women who did not start treatment. And what we found is Latina ethnicity was indeed a significant predictor of non-initiation of treatment. In other words, they attended no session. And after adjusting for severity of insomnia and depression and work status and parity, we found a significant association. However, other predictors we looked at, which I'm not showing statistic for, such as age, income, education, gestation week, involvement of the father of the baby, did not distinguish between those who did or did not start treatment. In terms of time to remission, you also found an advantage for CBTI over the control intervention. And what you see is that the median days for remission was 31 days for women in CBTI and 48 days for women in the control intervention, which I think is pretty powerful. And then the effect size in terms of number needed to treat for the difference in remission rates, not in the time to remission, which is, I think, easier to wrap your mind around, is 8, which is quite good. And a lower number is a better effect size. So let's look again, I'm still staying in the pregnancy period. Let's look at the diary-based changes in different measures of sleep for these women. So what you see in terms of their total wake time, there was a significant both main effect and interaction effect, so that women in the control intervention pretty much stayed flat, very little change, whereas women in CBTI reported significant decrease in total wake time overall. If you just look of WASO, which stands for wakefulness after sleep onset, which is time awake after sleep onset, there was also a significant interaction that very much parallels what you see in the total wake time, which is not surprising. But, and you look at time to fall asleep, what you see is a significant main and interaction again in each of them. So we remember the total wake time is the sum of sleep onset latency, the SOL, plus the WASO. So the two figures on the left, their sum is the figure on the right, on the very left, sorry. So total wake time is the sum of WASO and SOL. So it's not surprising. I'm just showing you the breakout. The total sleep time, however, was not statistically significant, very close. And what you see is the total sleep time for women in the control intervention was slightly increasing, whereas you have an inflection point where initially you have a decrease in total sleep time with CBTI, which is a function of the time in bed restriction. But as the time in bed window increased, you see a continuously nice and much more remarkable increase in total sleep duration, at least by self-report, and among the women in CBTI, not only compared to control, but also when I compare it to what we typically see in CBTI protocols in non-pregnant population, the time for increase in actual sleep duration takes actually, the magnitude of what you're seeing here is much bigger than what I'm used to in other CBTI protocols. The self-reported sleep quality is also interesting to look at. You see a main arm effect, but not a significant difference by arm by interaction, but by arm by time. But what I like to point out in here is this interesting increase in sleep quality, and as time goes on, there's a flattening of increase in sleep quality, probably reflecting the against the current that I talked about before, though I would say it's not a completely satisfying explanation because you don't observe it among the women in the control intervention. However, whereas you see nice changes in insomnia severity and in many of the sleep parameters, what you don't see is differential change in depression. So overall, during pregnancy, the curves are fairly parallel. It so happens that women in the ABTA group has slightly higher EDPS scores. And the overall effect in the decrease in EDPS scores was 0.4, and for change of at the end point, and for change it was only 0.1. So this is for the difference between them. So in other words, there was not much, the change was not that big. The two groups did not change differently. But there was a difference between them at the end, which I would not attribute to anything but the fact that we have a main effect that women so happened assigned to ABTI just had at baseline higher depression scores. And there was no differential impact on this null significance when we entered any of the control variables. So now I want to shift my attention to the postpartum. So remember, in the postpartum, there was one more session, and women were assessed at 8 weeks, 18 weeks, and 30 weeks postpartum. So if we analyze just the change during the postpartum from 8 to 18 to 30. And what we found in the mixed effect models is that there was no significant effect for time by arm. In other words, it didn't matter which intervention, I'll show you a graph in a minute, but it didn't matter which intervention you were assigned to, there was no difference between the two arms anymore. And I would say likely related to the fact that there's so much variance in sleep and during the immediate postpartum periods, particularly 8 and 18, up until 18 weeks, in taking care of the infant and so on, that it probably, the variance was, could explain why there's no difference. However, we then asked ourselves, does responding better during pregnancy moderate a change in ISI during the postpartum? And the answer is definitely yes. So what we did is we took the 18 weeks as the index, and we compared the change from 8 to 18 and the change between the groups, and the change from 18 to 30 between the two groups. And what we found is, so first of all, there was a difference in the response rate. So there were many more women who had at least 50% reduction in their symptoms during the pregnancy, whereas only 17% of the women assigned to the control intervention experienced at least 50% reduction in insomnia severity during pregnancy. So keep that in mind and look at the next slide. It's a little bit complicated, so let me walk you through that. What you can see is that those who had at least 50% reduction in symptoms during pregnancy, and remember, there's more of them in CBTI than in control. If they were allocated to CBTI, which is the dark circles, more than 50% reduction, they were very stable in terms of their insomnia severity throughout the postpartum time points. And when you compare them for those who have at least 50% reduction in symptoms in the control condition, which will be the black square, you will see that there's much less stable response, and the variability between people was very, very large. Whereas what you can see is a very tight distribution among the people in the CBTI condition. So there's something, although we did not find a difference between the two groups during the postpartum, what we found is a greater stability in symptom severity. In contrast, those who had less than 50% reduction, in other words, we categorize them as non-responders in general during the postpartum, and those will be the ones that are in the gray. They are generally having higher, regardless of which treatment they were assigned to, they have a higher insomnia severity also during the postpartum. So what you see is that it does make sense to treat insomnia during pregnancy, because improving insomnia during pregnancy contributes to less insomnia during the postpartum, regardless of how you got there. And you're more likely to have the effect be stable if you got there via CBTI. We also looked at changes in sleep based on both actigraphy and diary. And I want to tell you something about our, first of all, about, let's just focus on the left. So actigraphy is a way to measure objectively sleep through something akin to Fitbit and the like, something that's based on motion sensitivity. And what you can see is that women assigned to CBTI decrease the time they are awake at night overall from 8 weeks to 18 weeks. And remember, this just is based on motion. You don't know if they're awake taking care of the baby or they're awake because they're awake. But you generally see a decrease, and you can see a much greater, it looks like more great difference in the ABTI group, but it's actually not statistically significant. But then what you can see is that 18 weeks is roughly the time that women start returning to work. Babies are starting to sleep a little bit more. Women in CBTI continue to sleep more, to be awake for more or less the same amount of time, whereas women in ABTI worsened relative to 18 weeks. Again, these are just describing a pattern. This interaction is almost significant. It is actually, yeah, the interaction is not significant, but what you see is in terms of minutes, from 8 to 18 weeks postpartum, you have an overall decrease of time awake about 30 minutes. And overall, the sum of these two, the increase from 18 to 30, is approximately 10 minutes on average between the two groups. So it's not that big. But then the question is, what happens about the taking care of the infant? And in the diary during the postpartum, we actually asked women separately to report how long were they awake taking care of the infants, and how long were they awake returning to sleep after they are done taking care of the infant, or for any other reason. And when we just parse out the time to take care of the infant, you see that there's no difference between the two groups in terms of time that they took to take care of the infant, suggesting that the infant intervention that we've created is not particularly effective. It doesn't make a difference. But it means that when you interpret the wake time based on the objective, because the time to take care of the infant is the same, this likely reflects also reflects the time awake unrelated to infant awakening. So let me pause here and see if there are any questions before I move to a completely different topic related to this data set. Are there any questions in the chat? Anybody has any question? Now's the time. Okay. So let me move on. One of the things that we have also done in this study is we wanted to see whether there's a differential effect of both treatment and the impact of amount of sleep that women are getting or disturbance in sleep that women are experiencing on their ability to interact with their infant. And so what we've done is at 18 weeks, did I get out of slide mode? Here we go. So at 18 weeks, we had a home visit where moms were instructed to put a blanket on the ground and to play with the infant for 10 minutes with some toys of their choice. And we recorded that interaction. And then we coded, there were two different independent raters coded the videos for using the parent-child interaction rating scale. And they coded maternal sensitivity. However, instead of just coding the whole 10 minutes period, they coded each 2 minutes. So there were 5 segments of 2 minutes. And what we found is that there was no significant effect relationship between objective sleep continuity and the overall sensitivity of the mother. However, because we coded it by intervals, what you can see is if you look at women at the mean of time awake at night. It's not quite time awake, I'll tell you in a minute what it is, but best to think about it that way. Then there's relatively little, there's no association with her sensitivity, a change in her sensitivity, pretty stable. But those who had better sleep had sustained their ability to be sensitive to the infant, whereas those who have poor sleep lost some of it over time. So overall, there is a loss of sensitivity over time, but there is a significant difference between the two groups, suggesting that sleeping less interrupted sleep at night is more likely to result in better ability to sustain attention and sensitivity to the infant. That, to give you a kind of a sense of the clinical significance of that, we looked at it in 2 different ways. So if you look at what is the cutoff at which there starts to be a differentiation between losing attention or not, we identified a cutoff of 60 minutes as the time point by which you start seeing a difference, that it starts impacting the ability to attend to the infant. Another way to look at it is we compared women who were awake for less than 30 minutes to women who were awake for more than 30 minutes. And you see that women who were awake for less than 30 minutes, they were able to better sustain really nice sustainability. And women who were awake for more than 90 minutes, you can see a big drop. So there are different ways to look at cutoffs of where to draw the line. I think 60 minutes is what I would use. So in conclusion, I don't know why I have this, but let me have them all. I think we can say that CBTI is effective during pregnancy, that it didn't matter if you were Latina or you were low income, if you did it in Spanish or in English, you benefited. We also found that a good response to CBTI during pregnancy resulted in consistently lower insomnia symptoms during the postpartum, regardless of which intervention you ended up in. And that despite reporting equivalent time awake caring for the infant, those in CBTI experienced less worsening of their objective sleep from 18 to 30 weeks postpartum. And lastly, the last point to bring about is that poor sleep continuity was associated with poor ability of the mother to sustain her sensitivity to the infant over time. So I want to acknowledge a large team. It's been a very complex study to run. We had several RAs, all Spanish speakers. We have CBTI experts that have helped supervise the therapist. Nora supervised the CBTI therapist. Nora supervised the I supervised the CBTI therapist, Nora supervised the ABTI therapist, and Dawn monitored adherence to the intervention, and adherence to the intervention was very good. We had a study obstetricians, Deirdre at Stanford and Anita Hill at Santa Clara Valley. We have used some infant sleep experts that were on our team when we first established. Primarily, I would thank Liat Tikotsky, who's contributed a lot to the development of the infant sleep intervention. And these are the study therapists. And with that, I would like to thank you and stop sharing and see if you have any questions.
Thank you very much, Dr. Manber. I do have a question about the initial difficulty challenge in recruiting Latina pregnant people to the study, and the adjustment that was made is, as I understand it, was to recruit more providers and people who could speak in Spanish, who were bicultural or bilingual. And I'm wondering if you could expand on that a little bit. Was it just simply that piece in terms of engagement and then they stopped? Or was it what other factors?
No, actually, it's not exactly how it unfolded. So the reason we added the community bucket was not because of the Latina, it's because Stanford had other competing studies and they stopped allowing us to recruit from their clinics. We did recruitment directly in clinics, so we needed to find an alternative. And so we went with the community recruitment. So it really was not a replacement or necessarily mostly for Latina. To get the Latina, we partnered with Santa Clara Valley. We had a separate IRB in Santa Clara Valley. So that it was not to meet the challenge of recruiting Latina. To meet the challenge of recruiting Latina, from the very beginning, we had everything in Spanish. From the very beginning, the therapists were in Spanish, and we had the Spanish RA at the end. I had a Spanish-speaking therapist from a different study later on do the adherence rating for the Spanish tapes because we couldn't do it because we were not speaking Spanish. So all of it was already geared towards that. I think the big piece is that we were just present in the clinic. We were present in the clinic. We developed a relationship. We constantly were troubleshooting on how to do that. We developed a relationship with the front desk, with the midwives, and with the medical assistants, because they are the ones who ended up mostly referring. I did lots of talks to the obstetricians in Santa Clara Valley. It's just all about relationship. And having a co-investigator from a site that's rich in Hispanic population. I think to recruit Latina in general or Hispanic men and women is a challenge across all of our clinical studies. But the key here was presence. A lot of effort.
Thank you very much for that.
Yeah.
So Lauren, you can go ahead and unmute and ask your question if you're still able to.
Hi, Rachel. Great talk. Thank you so much. I was also wondering whether you looked at infant sleep at all as an outcome?
Not yet. So Ali is doing that as we are right now. So Ali is now, Ali Sai is one in the audience. I sent her a link. She is a visiting faculty from South Korea for a year with me, and she's very interested in the topic, and we're going to together analyze that. But just based on the time awake to take care of the infant being so tight between the two groups, I would imagine that to make a difference in infant intervention, it needs to be more proximal to when the woman actually experiences difficulty. And I treat clinically infants as well as children of other ages. And it is when the pain is there that you can do the analysis and help. John, were you trying to say something?
Please feel free to unmute. Yeah.
I have a question. Hi, Rachel. Thank you so much for a great talk. I'm curious what feedback you got from the therapists who delivered the intervention, just in terms of like the long-term sustainability of delivering this in person.
So these were graduate students and they loved it. So I don't know what kind of feedback you are talking about, but
yeah, I'm also curious in the just in terms of like scaling this intervention. Was it something that you got feedback from in the clinics where you were recruiting that this was something that they wanted to sustain, given
okay, yes. So definitely the clinics loved it that we've helped their patients sleep better. I did talk about sustainability and who will be, whenever I gave a talk to the obstetricians and I said, so if I wanted to bring this intervention to your clinic so you can do it, who will do it? And they could not think of anybody to do it. Some people said maybe social workers, some people, but I was thinking about health educators and folding it into health education. The feedback I got was that there isn't enough time for that and it's not a reimbursable service either. So I think, Jen, you work with a mobile version of CBTI is going to tell us a lot. And I think it is fantastic work.
Thank you.
Just to piggyback on that, so was the concern strictly around billing, or was it kind of competence or skill or
bandwidth?
Time?
It's about bandwidth. We don't have the bandwidth for that.
Okay.
That's the main thing. And I think the beauty and the potential of Jen's work, she's just getting funded to do a mobile CBTI among pregnant women. And I have a colleague that I collaborate with in Australia who just got funded in Australia to do a text-based intervention when there's a brief phone call with a person and then everything done via text and automated PDFs that are being sent for the women. So hands-off kind of delivery is probably the most promising in the context of CBTI for pregnancy. I will tell you clinically, we have a long wait list in our clinic, but when we get a pregnant woman, we bump her up the list because pregnancy is time limited. So getting services with a clinician is really pragmatically a challenge. We are lucky enough that we are living in a community in which there are plenty of CBTI trained specialists, but even so, we need to make a priority and bump them up in the wait list in order to treat them.
How would you think about the relationship piece, the relational piece and the engagement piece, if it's going to, if a switch to a mobile application?
That is a fantastic question. We have I have a postdoc in my lab right now who's very interested in that very idea. And we are interested in integrating mobile intervention into general mental health right now. And so we are interested in finding best ways to train mental health providers to integrate it by how to introduce it and how to support engagement in a self-help intervention so that you have the best of both worlds. So you absolutely are, you hit the nail on the same head that we are hitting the nail, basically.
Fantastic, thank you. Krista, go ahead and unmute yourself.
I had a question about women's perceptions of when they felt their sleep was becoming so abnormal as to need help. I just remember when I was pregnant, like the feedback I got from a lot of other women was, oh, like it's normal, like nobody sleeps when, they're pregnant and that kind of thing. And I'm just wondering, when did these women who were in the study kind of realize like this is more than what I would expect?
I wish I knew the answer, because my design does not allow me to answer this question, because I don't know, because I only know women who approached us. And I think in part the reason we had a hard time is because many women have this idea that it's normal. And I think the fact that we were so present in the clinic and we had our posters and we had brochures and we had our staff present has helped us recruit, but I don't know what was the tipping point for women to actually say, I need help. It's a great question.
Okay, well, I think this is great work. I really appreciate you doing this work.
Just one comment about that, just piggybacking on what you said, Krista, is, Rachel, as you pointed out, one of the most common reasons that potential participant was ineligible was because she didn't meet that threshold for insomnia, which was the same in my digital CBTI trial. And it seems like we had, and I think what you showed as well, so many people, pregnant women who were suffering from poor sleep and they wanted help, but they just didn't meet that threshold for clinical insomnia to warrant this particular intervention.
Yeah, and so the beauty of the work that Bay is doing in Australia, in Melbourne, Australia, is that she's not selecting women who have insomnia, but she selects women based on a threshold of severity of symptoms rather than meeting criteria for a disorder, which I think is a better way to go. To address both the previous person, Krista, it was? Yeah? Anyway. Looks like we've reached the hour.
We're almost there. I mean, this is such a critical work because there are lots of pregnant people in the world.
Yes.
And so this is sort of it's almost intuitive that we would need extra support around this time, and yet it is not readily and available. So appreciate this work and your work as well, Jennifer. Much appreciated. So yes, this is a time to wrap up, unless anyone has one last comment. Lots of thank yous, an excellent talk. I hope you're able to read those comments, Dr. Manber.
Yeah, thank you. Thank you.
All right, well, we're gonna call it then. Thank
Okay.
you, everyone. Have a great afternoon, and thank you for your time.
Okay,
Take good
care. Thank you all for
Bye-bye.
listening.